Hello, welcome to the channel Speaking Strength. Today we are going to discuss about jugular venous pressure. So, what are the contents? We are discussing what is JVP and what it indicates, where it is measured and why IJV is preferred over EJV, and how it is measured and what is considered to be an elevation, and how it is different from carotid pulse and JVP waveforms and the significance. So first of all, what is GVP? It is expressed as the vertical height of the blood column in the internal jugular vein above the sternal angle at 45 degrees. So it indicates right atrial pressure. It is measured in right internal jugular vein, not in external jugular vein, and left internal jugular vein. And where it is located? Right internal jugular vein is located in between the clavicular head of the sternocleidomastoid and the sternal head of the sternocleidomastoid, and here it is IJV and this one is EJV. So the next question is why IJV is preferred over EJV. So why IJV is preferred over EJV? IJV preferred over EJV because it is in direct communication with the right atrium, and also it doesn't have valves in between. If we take EJV has valves, so it may interfere with the measured JVP, and EJV pass through the multiple facial planes. And why left IJV is not considered? Because left IJV is not considered because of its tortuous nature. Next, how JVP is measured? Position the patient at 45 degrees and head slightly turned away from the side of examination. Then identify the highest point on the venous pulsation like this, and use a roller vertically from the sternal angle, and use second roller horizontally from the highest pulsation to meet the vertical roller like this. Then this value gives the JVP. So if it is less than 3 centimeters of H2O, it means no elevation. If it is more than 3 centimeters of H2O, it is raised JVP. So we add 5 centimeters of H2O to the measured value, like if you take 3 centimeters, to get a value that gives us JVP and right atrial pressure. So why we take 5 centimeters? Because anatomically the right atrium is located exactly 5 centimeters below the sternal angle. So more than 8 centimeters of H2O considered to be is elevation. Then differences between IJV and carotid pulse. So we often tend to get confused with the carotid pulse and jugular pulse. So first of all, let's discuss about it. IJV is actually superficial and lateral, and carotid pulse is deeper and medial. So IJV is better seen, carotid pulse is better felt. So IJV has two peaks and two troughs, and carotid pulse has a single upstroke only. So in digital compression abolishes the venous pulses, but digital compression has no effect on carotid pulse. And jugular venous pressure usually falls during inspiration, and carotid pulse does not alter with respiration. Then what are the causes of JVP? JVP causes are divided into pulsatile and non-pulsatile causes. And in non-pulsatile causes we have a Swiss obstruction. In pulsatile we again categorize it into cardiac and non-cardiac. In cardiac we have congestive heart failure, restrictive cardiomyopathy, tricuspid stenosis and tricuspid regurgitation, and cardiac tamponade. In non-cardiac causes we have COPD, carpulmonale, ascites, and pregnancy. Then let's talk about JVP waveforms. So it is the reflection of the pressure changes in the right atrium in different phases. So let's discuss about it. A wave indicates atrial contraction. Then X wave indicates atrial relaxation. Then C wave indicates tricuspid bulge into right atrium during isovolumetric contraction. Then V wave indicates V for venous filling. Then Y wave indicates atrial emptying, or this we can remember Y, or ventricular filling. Then we have one more wave called X dash. X dash when pulmonary valves open, tricuspid valve brought back to its normal position during ventricular contraction. So these are the representation of the waves. Then let's talk about waves in detail, and where we can see them: large waves or cannon waves, or absent or prominent waves. So first let's discuss about large A waves. So where we can see the large waves and why large A waves can be found. Okay, so large A waves can be found in atrial contraction against the resistance offered. So examples of large A waves is tricuspid stenosis, right ventricular hypertrophy, restrictive cardiomyopathy, and pulmonary arterial hypertension. So we can remember this as total valve replacement. Here this T indicates tricuspid stenosis, V indicates RVH, ventricular hypertrophy, and this R indicates RCM, restrictive cardiomyopathy, and P indicates pulmonary arterial hypertension. Okay. Then next one comes cannon A waves or giant A waves. We can see this is the cannon A wave. So where we can see giant waves or cannon A waves. So atrial contraction against closed valve. Here the atrial contraction in above large A waves, atrial contraction against the resistance offered, and here atrial contraction against the closed valve. So what are the examples for this? Arrhythmias and complete heart block. We can remember this as AC can provide cooling only if doors closed. So here AC means arrhythmia, a congestive heart block, not a good mnemonic. But next one is X wave. X wave indicates atrial relaxation, and the X dash wave. So it represents pulmonary valves opening and tricuspid valve drag back into its normal position. So we can see prominent X descent in constrictive pericarditis and cardiac tamponade. Then comes the C wave. C wave indicates tricuspid bulge during isovolumetric contraction. Here we know that tricuspid bulge during isovolumetric contraction. So then comes the V wave. V wave means venous filling. or passive atrial filling. So where we can get the prominent V wave? Prominent V wave means there is increased atrial filling. So increased atrial filling can be happen in two cases. For example, in tricuspid regurgitation, AST. So we take, this is right atrium and this is left atrium and this is right ventricle. So if we have AST here and the right atrium getting blood from the superior vena cava and also from the left atrium, so there is more incoming blood. So similarly in tricuspid regurgitation, right atrium getting blood from the above superior vena cava and also from right ventricle. So there is chance that there is increased atrial filling. So the next one is very interesting, CV wave. So CV wave only seen in tricuspid regurgitation because, so to have CV wave, X wave excitation should not be there. In tricuspid regurgitation, so actually indicates relaxation. So when atria gets relaxed, when it pours down all its blood to the right ventricle. So in tricuspid regurgitation, the right atrium is throwing its blood to the right ventricle, but right ventricle is throwing the blood back to the right atrium through tricuspid valve. So in tricuspid regurgitation, there is no time for the atria to get relaxed. So there is no formation of X wave. So there is formation of CV wave. So here it indicates CV wave. It is seen in tricuspid regurgitation. Okay, then Y wave. Y wave, it represents the atrial emptying. Y wave represents atrial emptying or ventricular filling. So where we can see the prominent wave, prominent Y descent, rapid filling of ventricle or rapid throwing of blood into the ventricle. So it is seen in constrictive pericarditis, and absent Y wave, Y descent is seen in cardiac tamponade because atria is throwing its blood to the right ventricle, but right ventricle is not compliant enough to take the blood, because in cardiac tamponade the pericardial sac is filled with the fluid and it is uh, no more chance for dilatation of the ventricle. So if you have if you see pericarditis starts with P and P for prominent. So prominent X and Y seen in pericarditis. Then the next one is Kussmaul sign. Kussmaul sign is actually defined as it is a paradoxical rise in JVP during inspiration. So normally or usually during inspiration there is fall in JVP because of decrease in the intrathoracic pressure. The venous return will increase and there is enough space for the pericardium and for the pericardial sac or pericardium or the heart right ventricle to dilate and accommodate all the blood coming into it. But in some conditions the right ventricle cannot accommodate and right ventricle cannot receive all the blood coming from the right atrium. So those are constrictive pericarditis, restrictive cardiomyopathy, right ventricle failure and right ventricle infarct. So this is all about JVP. Thank you.